Hello everyone, a very good morning to all of you. Am I clearly visible, audible? You have to confirm in the chat box. If I am clearly visible, audible and live also, I will start the session. Can anyone confirm in the chat box please? If visibility, audibility, everything is good to go. Please confirm in the chat box and write down if it is clear. I guess it's working, right? Let me confirm, just a second. Am I clearly visible, audible? Okay, it's good to go. So I welcome you all for today's session. Very good morning to all of you. So today we are going to continue our oncology series. In this oncology series, we have completed many tumors till now. We have completed breast tumor, brain tumor, many tumors we have completed in the last episodes. And here, specifically today, I'm going to take hemato-oncology. Just a second. I'm going to take hemato-oncology. So basically, I'm going to cover all the leukemias and lymphomas in today's session. So today's session is going to be ultra important for whatever competitive exam or medical entrance exam you are preparing for. Leukemias and lymphomas is the ultra important topic, and you get many MCQs. And if you are preparing for your professional exams also for the medical in any medical prof, then also this hemato-oncology is going to benefit you a lot. Okay, so without wasting any further time, let me start with the hemato-oncology, that is leukemias and lymphomas. So before coming what is leukemia, what is lymphoma, you must understand the basics. Now in human body we have blood. In the blood we have three type of cells, RBCs, WBCs and platelets. Now how many type of WBCs are there? How many type of WBC is there? There are two type of WBCs, granulocytes and agranulocytes. What do you mean by that? Granulocytes are the WBCs which have granules in their cytoplasm, and agranulocytes are the WBC which don't have granules in their cytoplasm. So basically there are three type of granulocytes, that is neutrophil, eosinophil and basophil. You can see the granules. Neutrophils have purple, pink or purple granules in the cytoplasm. Eosinophil have red color, brick red color granules in the cytoplasm, and basophils have dark blue or black color granules in the cytoplasm. So you can appreciate the three type of the granulocytes. Now agranulocytes are the WBC which don't have granules in their cytoplasm. So there are only two types, lymphocyte and monocyte. You can see lymphocyte, the nucleus is big and hardly you can see a rim of cytoplasm around, but the cytoplasm don't have the granules. And similarly there is monocyte. You can see the monocyte, you can see the kidney is the nucleus is the horseshoe shaped, kidney shaped nucleus is there. So this is the monocyte, they don't have granules. So total 5 WBCs are there. Now my next question to you, where does these WBC, all 5 of them are formed? Where does they form? Give me a minute, just a second. So can you tell me where does these WBCs are formed? So all these WBCs are formed in the bone marrow. They all are formed in the bone marrow. So how does they formed in the bone marrow? So let me draw a bone marrow for you. This is a bone marrow. Okay, here I can see the bone marrow. In the bone marrow, the first cell is hematopoietic stem cell. The first cell, he is the father and sister of all cells. All the precursors are arise from this only. So RBC, WBC as well as platelet, everything is formed from this. Now from this precursor, please understand this is basic. If you understand this, understanding leukemia and lymphoma will be fun for you. Listen, so from the hematopoietic stem cell, two precursors are formed. One is myeloblast and one is lymphoblast. One is myeloblast and one is lymphoblast. This myeloblast give rise to all the RBCs. RBC don't have any further type. This myeloblast give rise to platelet also. Platelet don't have any types, all the platelets. Now among the WBC, the myeloblast give rise to 4 WBC. So all the granulocyte, that is neutrophil, eosinophil, basophil and monocyte. From the agranulocytes it's monocyte. So out of the 5 WBC, 4 are formed from myeloblast only. Now what is left? Only lymphocyte is left. So basically lymphoblast give rise to lymphocyte only, one of the WBC. So this is, that's why we call myeloblast as trilineage. What do you mean by trilineage? Triple lineage, trilineage. What do you mean by trilineage? It give rise to 3 lineage. It give rise to RBCs also. It give rise to platelet also. Not only this, it give rise to maximum WBC except lymphocyte. That's why it is known as trilineage. And lymphoblast give rise to lymphocyte only. So this is known as myeloid series, and this is known as lymphoid series. How many of you got it? How many of you got it? Is the sound low? Is it clearly visible, audible? Audibility is good, or is there is any trouble in the audibility? Is the audibility is good or any trouble in the audibility? Kindly let me know in the chat box. Am I clearly visible as well as audible, or there is a trouble in the audibility? Hmm? So is it good? Can we continue? Okay. Thank you for confirming. So let's continue. So I told you that how does the WBCs are formed in the bone marrow. You can see how does WBC are forming. So there are 5 WBCs. So same thing is written. So from the hematopoietic stem cell in the bone marrow, as I told you, hematopoietic stem cell. From the hematopoietic stem cell in the bone marrow, two things are formed. है ना? Myeloblast, which is trilineage, and lymphoblast. Myeloblast give rise to RBCs also, it give rise to platelet also, and among WBC, it give rise to 4 WBC. That is neutrophil, eosinophil, basophil, and monocyte. It don't give rise to lymphocyte. So only one of the WBC is left. That is lymphocyte, and that is arising from the lymphoblast. I hope everyone got it. Okay, everyone got it. So can I take a pause and like do the settings for the sound? Shall I do that? Sound is low. So give me a minute. Give me a minute. I will be back in a minute. Let me fix this sound issue. Okay? Shall I start the session? Is it working? Can you people confirm? Is the audio is good? Is the audio is working now? Is it fine? Is it working good? Can you confirm? I'm just checking the audio. Hello? Can you people confirm? Is the audio is good? I guess it's working. I guess it's working. Okay. So let me continue. Okay. So now the audio is good. I guess the problem is resolved. Can we continue? Just a second. Okay. So I was telling you what are leukemias, what are lymphomas. So today we are going to cover leukemias and lymphomas, that is hemato-oncology. So before coming on the topic, I was giving you an overview that how does the WBCs are formed in the bone marrow. So I have told you that all the WBCs are formed in the bone marrow only. Inside the bone marrow, the precursor cell is the hematopoietic stem cell. That is the ancestor cell. That give rise to all the cells. That give rise to all the blood cells. It give rise to RBCs also, WBCs also, platelet also. So basically from the hematopoietic stem cell, the main cell which is formed, there are two ancestral cells, the precursor cells which are formed. The myeloblast and the lymphoblast. These are the two cells. Myeloblast give rise to RBC also. It give rise to platelet also. And among the 5 WBC, it give rise to 4 WBCs. That is neutrophil, eosinophil, basophil and monocyte. It do not give rise to lymphocyte. The lymphocyte is arising from the lymphoblast. So this is the overview, you got it till now, right? Now the same thing is written here. You can see a bone marrow here. Inside the bone marrow you all can see a hematopoietic stem cell. From the hematopoietic stem cell, the myeloblast and the lymphoblast are arising, you can see. Now we will see the precursors in between. We know myeloblast give rise to neutrophil, eosinophil, basophil, monocyte. But what are the precursors in between? You have to learn that. And lymphoblast give rise to lymphocyte. But you have to learn the precursors in between. Yeah, you have to learn the precursors. So let me tell you the precursors one by one. So in myeloblast, it gives rise to neutrophil. There are 4 precursors in between. That is promyelocyte, myelocyte, metamyelocyte and band form. I will show you the diagram also. I am saying the first cell is hematopoietic stem cell. It gives rise to myeloblast. From the myeloblast, the next cell which is formed is promyelocyte, followed by myelocyte. Promyelocyte, myelocyte, metamyelocyte, then band form, and finally neutrophil is formed. The neutrophil which is formed finally, it will come in the blood. Precursors do not come in the blood. So you can see finally the mature forms are coming in the blood. The neutrophil is coming and the lymphocyte are coming. The precursors don't come in the blood. But you have to learn the sequence of the precursor. Promyelocyte, myelocyte, metamyelocyte and band form. Got it? These are the sequence of the precursors on the myeloblast. In the lymphoblast, only one precursor is there. The lymphoblast gave rise to prolymphocyte and finally lymphocyte. So I'm summarizing. I'm just summarizing. Have a look here, then we are going to start the leukemias. Listen. Now this is a bone marrow. You all can understand this is a bone marrow. The first cell I taught you here is the hematopoietic stem cell. It is given rise to 2 blasts, the 2 precursors. Myeloblast, which is trilineage, and lymphoblast. Now tell me the precursors here. Myeloblast give rise to what? Myeloblast give rise to promyelocyte. Promyelocyte give rise to myelocyte. And then it gives rise to metamyelocyte. Promyelocyte, myelocyte, metamyelocyte. Then band form. And finally neutrophil is formed. In the same way, eosinophil and basophil and monocytes are also formed. But we are looking the precursors only of neutrophil, not of others right now. But it is in the same way. Now coming on the lymphoblast. Lymphoblast give rise to prolymphocyte. And finally it gives rise to lymphocyte. So the mature form are, here we have neutrophil and here we have lymphocyte. They come in the blood. The precursors do not come in the blood. The precursors do not. We have these precursors, but in our bone marrow. The mature form come ultimately in the blood. You can see the mature form are running in the blood. How many of you got it? You got this concept? You can see. Now, this is normal. In my blood, your blood, all healthy individual blood, this is normal. By normal, I mean the mature forms are there. So if you check the blood of any healthy individual, you will get neutrophil, eosinophil, basophil, monocyte and lymphocyte. You don't get the precursors of them in the blood, right? Now what is leukemia? Now you can understand what is leukemia. Leukemia is arrival of blast in the blood. Arrival of blast in blood. We have blast in bone marrow, it's normal. Having myeloblast and lymphoblast in the bone marrow is normal. But once the blasts are spitted in the blood, once they are coming in the blood, it is known as leukemia. So what is leukemia? Leukemia is blast in the blood. It is blast in blood. It is not normal. It's an abnormal finding. Now you may be thinking why these blasts are coming in the blood. They are present in the bone marrow. Now these are the precursor. So two type of blasts are there. Myeloblast and lymphoblast. Both of them can come. If the myeloblast is coming in the blood, it's known as myeloid leukemia. It is known as myeloid leukemia. And if lymphoblasts are coming in the blood, it's known as lymphoid leukemia. So basically leukemia is of two types, myeloid and lymphoid, depending which blast is coming. I hope you are getting it. If myeloblast is coming, say it's myeloid leukemia. If myeloblast is coming, it's myeloid leukemia. And if lymphoblast is coming, it's lymphoid leukemia. Got it? So there are two type of leukemia we are having. Now you may be thinking why these blasts are coming in the blood, leaving the bone marrow, why they are coming in the blood. So in these blasts, certain mutations takes place. I will tell you the exact mutation also. So certain translocations, mutations, different type of mutations takes place in different type of leukemia. Because of the mutation, they become proliferative, super proliferative. They keep on dividing, and they convert into cancer cell. What is cancer cell? They are immortal and they divide without stimulus. So without any stimulus, they keep on dividing, uncontrolled cell division. Since they do uncontrolled cell division, they are spitted in the blood. They are very much in number and they just come in the blood. So that's why it leads to leukemia. So there are certain mutations which leads to uncontrolled cell division in these blasts, and the blasts are coming in the blood. How many of you got it? You got it? Do you have any confusion? So this is leukemia. I hope everyone got it. So can I say leukemia is arrival of blast in the blood? Arrival of the blast in the blood. When the blasts are coming in the blood, blast in blood, it is known as leukemia. These blasts, the blasts are coming in the blood, it's leukemia. So can I say leukemia is a blood cancer? Yes, the other name of the leukemia is blood cancer. You don't find any solid tumor in the body. You cannot find the boundaries here. It's the blast present in the blood. It's fluid. You know, it's blood cancer. Now, sometime what happens, these blasts will go and accumulate in the solid organs. It can be spleen, liver, lymph node, and many organs. Hai? So, and it will produce the discrete tumors in the solid organ. That is known as lymphoma. Hai? So, lymphoma is the tumor in the discrete organs. But leukemia is blood cancer. I hope everyone got it. Do you have any confusion? Please ask. So first we will see leukemia, then we will see lymphoma. First we will see leukemias and then we will see lymphomas. So leukemia is blast in the blood and we will see the classification. So as I told you, the leukemias are of two types depending which blast is coming. As I told you, there are two types of blast, myeloblast and lymphoblast. So basically when myeloblast is coming in the blood, it's known as myeloid leukemia. Myeloblast is coming, it's myeloid leukemia. And when lymphoblast is coming in the blood, it's lymphoid leukemia. So there are two types of leukemia, myeloid and lymphoid. You can see myeloid and lymphoid. Each of them can be of two types, acute, chronic, acute, chronic. So there are four types of leukemia, you can say. So what are the four types, can you say? Say ma'am, acute myeloid leukemia known as AML. You can say chronic myeloid leukemia, that is CML. Acute lymphoid leukemia, that is ALL, and chronic lymphoid leukemia, that is CLL. So this is the overview. Now we will start the four leukemias one by one. We have seen there is a bone marrow and we have seen this is the blood vessel. We have seen how does the WBCs are formed in the bone marrow from the hematopoietic stem cell, the ancestral cell that give rise to all the cell. So we have seen there are two types of blast, myeloblast and lymphoblast, and there are many precursors in between. So myeloblast give rise to promyelocyte, myelocyte, metamyelocyte. Learn the sequence. Promyelocyte, myelocyte, metamyelocyte, band form, and finally neutrophil. The lymphocyte give rise to prolymphocyte and lymphocyte. Hana. So here the mature form is this, and they are coming in the blood normally in healthy individual. They have the mature form in the blood. The precursor do not come in the blood. They never come in the blood. But in leukemia, what is happening? The precursors are coming in the blood. The blasts are coming in the blood. When the blast, myeloblast or lymphoblast come in the blood, it's known as leukemia. It's abnormal. And why they are coming? Due to the mutation. In myeloblast and lymphoblast, certain mutations, I will tell you exact mutation taking place, leading to uncontrolled cell division. Once they have uncontrolled cell division, they are spitted in the blood. Got it? So myeloblast when coming in the blood, it is known as myeloid leukemia. And lymphoblast when coming in the blood, it's known as lymphoid leukemia. So there is myeloid leukemia and there is lymphoid leukemia. There are two types and each one of them can be acute, chronic acute chronic. So we have 4 types of leukemia. This is acute myeloid leukemia, AML, chronic myeloid leukemia, CML. Both of them are myeloid in nature. This is acute lymphoid leukemia and chronic lymphoid leukemia. Both of them are lymphoid in nature. Give me a thumbs up. Got it? Anyone? Mutations, Kiran, I will come on the exact mutation. I am going to teach you all the 4 leukemias one by one. So these are the 4 types of leukemias in front of you. You can see broadly we divide them into 2, myeloid and lymphoid. You can see lymphoid when lymphoblasts are coming in the blood, myeloid when myeloblasts are coming in the blood. Each one of them is acute, chronic, acute, chronic. So finally we are left with the 4 leukemias, ALL, CLL, AML, CML. I assume you know the full forms of each of them. So that is the overview. Now the main difference between the myeloid and lymphoid is the myeloblast or lymphoblast. Which blast is coming in the blood? So you must understand the morphology of myeloblast and lymphoblast. How does they look like? If myeloblast is coming, it's myeloid leukemia. If lymphoblast is coming, it's lymphoid. So how does they look like? The 2 diagrams are in front of you. Myeloblast is little bit larger in size and lymphoblast is very small in size. Everyone got it? Myeloblast is larger in size, lymphoblast is smaller. We can see. There is moderate cytoplasm in myeloblast, but there is hardly any cytoplasm in the lymphoblast. In the lymphoblast, this is complete nucleus. This is complete. I hardly found any cytoplasm. I can't found any cytoplasm here. So cytoplasm is very scanty here. But here it is moderate. The most important difference is the iron rod. Can you see? What is iron rod? Iron rod. Iron rod, can you see this? This rod-like structure. The rod-like structure present in the cytoplasm of the myeloblast, but it is never present in lymphoblast. So iron rod may be present, it is not always, but may be present in myeloblast and it's always absent in lymphoblast. Based on the iron rod, we can differentiate the 2. Okay, this is the classification of the leukemias. Now in lymphomas, the classification is different. We divide them into 2 categories, Hodgkin and non-Hodgkin, based on the RS cell, Reed-Sternberg cell. I will tell you what is Reed-Sternberg cell. If RS cell is present, it's Hodgkin's lymphoma. If RS cell is absent, it's non-Hodgkin's lymphoma. So we will see the lymphomas later on. Let me first finish the leukemias and then we will come on the lymphomas. What you are saying? Okay. What you are saying? Okay, so can we go ahead? So you tell me. So there are 4 types of leukemias, CML, AML, ALL and CLL. We will see the details one by one. So I want you to make this table along with watching the session. It will be very useful for you. You can have a comparative analysis between the 4 types of leukemia if you are making this table with me. So I want you to compare the 4 types of leukemias in a fixed set of heading. Introduction, age, pathogenesis, classification, clinical feature, lab diagnosis, treatment and prognosis. So how many of you are with me? Give me a thumbs up. Give me a thumbs up in the chat box. Can I start? Are you people with me? Can I start? Can I start? So let's start. Let's start with the first leukemia, CML. Start filling this table with me. Let's start with the first leukemia, CML. In a fixed set of heading, I am going to cover these. So let's start the first one, chronic myeloid leukemia, CML. In the introduction, you have to write the definition. So CML is a leukemia having 4, it is characterized by 4 important findings. Number 1, the patient have increased WBC count. What is the normal WBC count? In our blood, we have RBCs, we have WBCs, and we have platelet, normal healthy individual. So what is the normal RBC count? It's 4.5 to 5.5 million per deciliter. This is the normal count of RBC. WBC is just 4,000 to 11,000. It's not million. 4,000 to 11,000 per deciliter. And platelet is normally 1.5 to 4 lakhs per deciliter. The first finding, you should know the normal count. Here I am saying that in CML the WBC count is raised. How much? The highest normal is 11,000. The highest normal for an adult human being, it's 11,000. But here it will be in lakhs. It can be 1 lakh, it can be 2 lakh, it can be 3 lakh, it will be in lakhs, not 11,000. It is in lakhs. So here leukocytosis is there. WBCs are too much in the blood. Basically, most of the WBCs may be basophils also. Basophilia is also a feature. Splenomegaly is there and Philadelphia chromosome is there. What is Philadelphia chromosome? I will tell you. Let me come on the Philadelphia chromosome. So these are the 4 findings in CML. CML always occur in old age, after 50 years of age. Age will always give you a clue. The age of the 4 leukemias is very typical. Looking at the age of the patient, you can have suspicion that patient is maybe having which type of leukemia. So age is always important. Age is always important. Okay. So here the patient presents usually in old age after 50 years of age. Usually. Exceptions are there, but usually. Now coming on the pathogenesis. I told you this is the bone marrow. In the bone marrow, tell me the precursors. Tell me the sequence of the precursors. So this is hematopoietic stem cell. Hematopoietic stem cell. I am interested in myeloblast. Currently, I am not interested in lymphoblast. I am teaching you myeloid leukemia. So tell me the precursors here. So what are the precursors I told you? First from the myeloblast promyelocyte, then myelocyte, then metamyelocyte, then band form, and then neutrophil. Hana? In the same way, eosinophil and basophil are also formed. Right? This is the thing. Normally, only the mature forms are coming in the blood. These three mature forms are coming in the blood. Their complete precursors are not coming in the blood. Mind it. But now, in all these cells, myeloblast, promyelocyte, myelocyte, metamyelocyte, band form, certain mutations takes place. Let me tell you which mutation. Certain mutations takes place because of which all these precursors are doing uncontrolled mitosis, uncontrolled cell division. So they all will be spitted in the blood. So basically in CML we get myeloblast, promyelocyte, myelocyte, metamyelocyte, band form in the blood. All the premature forms will be present in the blood along with a little bit of neutrophil, eosinophil and basophil. A little bit. I mean the mature forms are less. The immature forms are more. Immature forms, and it is not one immaturity. All the immature forms are coming. So basically once you make the smear, you get all type of cells. I will show you the diagram also. It is known as garden party appearance. Why it is known as garden party? What is garden party? In a garden party, everyone is in different dress. It is opposite of uniform. In a school, everyone is in a uniform. In a garden party, everyone is in a unique dress. So garden party meaning we are getting multiple type of cell. We are getting myeloblast also, promyelocyte, myelocyte, metamyelocyte, band form. We are getting all different type of immaturities in the blood. How many of you are getting it? Got it? So this is the CML. Now you may be thinking, ma'am, what is the exact mutation taking place in all these cells? Let me tell you the exact mutation. Now for that you tell me human cell have how many chromosomes? This is a human cell. Now it can be myeloblast, it can be promyelocyte, it can be myelocyte, it can be metamyelocyte, band form. It can be any of them. Now all the human cells have how many chromosomes? All the human cells have 46 chromosomes. These all cells or all cells have 46. Better to say 23 pairs. Normal humans have 23 pairs. Pair number 1, pair number 2, pair number 3, 4, 5, 6, likewise. Total 23 pairs are there. Currently, I am interested in two pairs. Pair number 9 and pair number 22. So on the next page, I am drawing the two pairs. Pair number 9 and pair number 22. So this is pair number 9. This is pair number 9. Okay. And this is pair number 22. Okay. I am drawing the two chromosomes pair. Pair number 9 and 22. 9 and 22. Okay. Normally in all healthy individual, you, me, everyone, pair number 9 have a gene. The name of the gene is ABL. It's normal. We all have it. ABL. ABL is doing its normal function. When the stimulus is coming, it is doing the cell division. Without stimulus, it is not doing the cell division. On 22, we all have another gene. The name of that gene is BCR. Again, it is present in all healthy individual. And it's normal. It's under control. I mean, whenever stimulus is coming, then only it's dividing. It's dividing the cell. Otherwise, it's not dividing. That is, it is under control. This is normal. Now, this is inside the cell. Inside the nucleus of the cell, these all are present. Total 23 pairs are present. But I am not drawing 23 pairs. I am drawing only 9 and 22. Now, due to certain mutation, the mutation can be physical, chemical, biological. Any type of mutation, carcinogenesis can be there. Because of which actually translocation take place. What is taking place here? Say translocation. Translocation is taking place. What do you mean by translocation? It is balanced translocation. What do you mean by balanced translocation? A portion of 9 is given to 22 and a portion of 22 in exchange is given to 9. They are exchanging a little part of their chromosome. Got it? So here 9 is giving this portion to 22. Actually 9 is giving ABL to 22. So ABL is gone to the 22 now. ABL is gone to 22. So on 22, BCR was already present. BCR was already present and ABL will also present now. ABL will also. So ABL BCR, a new gene is formed. That is known as ABL BCR fusion gene or ABL BCR hybrid gene. That is deadly. That is deadly. Whenever the two genes were separate, they were doing cell division under control. Whenever stimulus was coming, then only the cell was dividing. But once they fuse or they form a hybrid, that the hybrid gene, the third gene which is formed because of the fusion of the two genes, is very deadly. It's doing the cell division uncontrolled. It is leading to uncontrolled mitosis because this hybrid gene is forming a enzyme. The name of the enzyme is abnormal tyrosine kinase, not normal, abnormal tyrosine kinase, and that abnormal tyrosine kinase is doing uncontrolled division of the cell. Uncontrolled division of the cell. Because of the uncontrolled division, their number increases too much and they are spitted over in the blood. How many of you got it? And this cell can be myeloblast, promyelocyte, myelocyte, metamyelocyte, band form, anything. So all the prematurities will come in the blood. How many of you got it? Now you may be thinking, ma'am, 9 has given ABL wala portion, the segment which contain ABL to 22. What in exchange the 22 is giving to 9? 22 is giving a portion to the 9 which doesn't contain any important gene. So 22 is also giving a portion to 9, but it doesn't contain any important gene. So basically on 22 the hybrid is formed. It's also a very important PYQ, very important question. The hybrid gene is formed on 22, not on 9. That's why chromosome number 22 is known as Philadelphia. That's why chromosome number 22 is known as Philadelphia chromosome. This is Philadelphia, not 9. Chromosome 9 is not Philadelphia. Chromosome 22 is Philadelphia. How many of you got it? Kindly respond. Give me a thumbs up. I appreciate. Give a gesture that you got it. Any confusion? And this one is known as 922 translocation. 922 translocation. It is written like that. That is leading to CML. This is the reason for the CML. Got it, everyone? So what is the reason for CML? Say it's 922 translocation. Either say translocation 9 and 22. Between these are the number of the chromosome, or you can write the name of the gene. Instead of 9, write down ABL, and instead of 22, you can write down BCR. So it's also known as ABL BCR translocation. ABL BCR translocation. Any confusion? Any confusion? Shall I proceed? So you can see this mutation taking place in all these cells. The 922 translocation. It is taking place in promyelocyte, myelocyte, metamyelocyte, band form. It is taking place in all the precursors. So all the precursors will be spitted in the blood. So the same story is written in front of you. ABL present on 9. BCR present on 22. This is normal. This is normal. And they form an enzyme which is normal tyrosine kinase. Normal. Now you can see the same diagram. You can see these two chromosomes. Can you see chromosome number 9, the two arms? And see the chromosome number 22, the two chromatids you can see. Now I want you to appreciate the gene ABL on 9. This is a gene which is present on 9. And I want you to appreciate the BCR, the yellow color, the BCR on 22. Normally ABL is on 9, BCR is on 22. There is no problem in that. This is also forming tyrosine kinase. This is also forming tyrosine kinase. It's normal. It's doing normal activity. But now they are doing exchange. 9 is giving ABL to 22. So basically on 22, the hybrid is formed. ABL BCR hybrid, ACL BCR fusion gene. That is forming abnormal tyrosine kinase leading to uncontrolled mitosis. Okay, I guess everyone got it. Yes, this is balanced translocation. So you can see the same story is written. ABL is present on 9. It is translocated on 22. So on 22, it fuses with BCR. And on 22, the ABL BCR fusion gene is formed. That is known as Philadelphia chromosome. Philadelphia chromosome. The size of Philadelphia chromosome because of the fusion, it is 210 kilodalton. You have to learn this. And you get questions on that. And it is leading to abnormal tyrosine kinase leading to uncontrolled mitosis. And that's why it is leading to CML. Right? So because of this fusion, an abnormal enzyme is formed. That is tyrosine kinase. Now what is the treatment of CML? There is a targeted drug available. Does anyone know the name of the targeted drug? Anyone from the students, from the audience? Does anyone know the name of that targeted drug I am asking?
Is the audio working now? Is it fine?
So what is the name of that targeted drug? The name of that targeted drug is imatinib. Imatinib. What does the imatinib do? Imatinib is the first targeted therapy. Imatinib inhibit, do the apoptosis of all those cells which is having this fusion gene in them. So all the Philadelphia chromosome cells are destroyed. Apoptosis is done by the imatinib, and it destroys the abnormal tyrosine kinase. So imatinib is the targeted therapy. Yes, absolutely right. It's imatinib. You get questions on that. Now I'm coming on the phases of the CML. CML have 3 phases: chronic phase, accelerated phase, and blast phase. You can learn a mnemonic CAB: chronic, accelerated, blast, the triphase. Now you have to see what I'm saying. Listen again. This is the bone marrow, this is the blood. Here I am saying this is hematopoietic stem cell. This is lymphoblast. I am not interested in that. Currently I am interested in myeloblast. So what are the precursors? Can we revise it once? What are the precursors? Say ma'am, promyelocyte, myelocyte, metamyelocyte and band form. And finally neutrophil, eosinophil, basophil, these are formed. Hana? So I am saying these all, mutation is taking place in these all. So there is uncontrolled mitosis in these all. In these all the same thing is happening, 922 translocation. And because of which there is uncontrolled mitosis in all of them. And these all are coming in the blood. These all prematurities are coming in the blood. So in the blood we are getting myeloblast also, promyelocyte also, myelocyte also, metamyelocyte also, band form also. We get mature forms also, but very less in number. Very less in number. Got my point? And that's why if you see the normal count in the blood, WBC count, normal count is 4,000 to 11,000. But here since all the immaturities are coming, the count will be 1 lakh, 2 lakh, 3 lakh, it will be in lakhs, not in thousand. But most of the cells are immature. You are not increasing the count of the mature. Mature are less even than normal. Even than normal. Mature are less even than in comparison to normal. All of them are immature. So I am saying even the person is having high counts of WBC, person is highly susceptible to infection. The two statements are contradictory. What I am saying, the WBC count is too high. You may be thinking, ma'am, WBC is the army, it's the defense. If the WBC count is high, person should have low susceptibility of infection. I am saying no. The patient is having high count of WBC. High, it is in lakhs. Still patient is highly susceptible of infection. Why? Because all of them are immature. They are not mature. Right? So person is highly susceptible of infection. Currently I am telling you the three phases, chronic, accelerated and blast. The three phases of the CML, it based on myeloblast. I agree all the prematurities are coming, but the most important prematurity is coming is the myeloblast. The blast, you have to see the percentage of blast. How many blasts are coming in the blood? How many blasts? What is the percentage of blast coming in the blood? That decide whether the person is in chronic phase, accelerated phase or blast phase. Right, say something, got it? So if it is less than 10% of the blasts are coming, it's chronic. 10 to 19, it's accelerated. And more than 20% of the blast in the blood, it's blast phase. It's an emergency, the blast phase. So less than 10, 10 to 19 and 10 to 19 and more than 20%. How many of you got it? So that is chronic phase, accelerated phase and blast phase. These are the three phases in front of you. So that is CML, the three phases of the CML. Now let me come on the clinical feature. So as I told you, in the bone marrow, what happens in the bone marrow? There is hematopoietic stem cell. We have to see this again and again. Lymphoblast, myeloblast. So I told you, lymphoblast give rise only to lymphocyte. But myeloblast give rise to three things. It gives rise to RBCs also, it gives rise to platelet also, and it gives rise to 4 WBC, neutrophil, eosinophil, basophil and monocyte. Now I am saying that the myeloblast is having mutation. It is having mutation. Basically the precursors of these cells, that is promyelocyte, myelocyte, metamyelocyte, band form, they all have the mutation. They all have the mutation. Because of the mutation, they are doing uncontrolled mitosis. So because of the uncontrolled mitosis, the complete marrow is filled with these cells. So hardly you will get any RBC, hardly you will get any platelet, so you will get only WBC, but mind my words, that too immature. I am not saying mature WBC, the immature WBC, the complete marrow is filled with immature WBC. So patient presents with anemia because RBCs is not formed. Patient presents with thrombocytopenia or bleeding disorder because the platelets are not formed. And patient presents with high susceptibility of infection. Although I am saying the patient is having high WBC, still the patient is having high susceptibility of infection. Got it? So these are the three symptoms. These are the three symptoms. Anemia because RBCs are not formed. Thrombocytopenia or bleeding because platelets are not formed. And high susceptibility of infection, I agree WBC are formed more, but they are immature. Kindly respond people, say something, ask, write down in the chat box. It's a live session, you can interact with me. Yes? So Nomads, Cortex, Jui Lang, anyone other having any doubt? Can we go ahead? So these are the three symptoms due to bone marrow failure. It is known as bone marrow failure. The complete marrow is filled with the blast only, the prematurities. So here the patient don't have RBC, so patient have anemia. So patient will be having complaint of lethargy, dyspnea, pallor. Patient will be having complaint of bleeding disorders. right? Bleeding disorders due to thrombocytopenia. So patient have complaints of bruise, pateki, and patient is having complaints of high susceptibility of infection. Although WCs are more, but they are immature. And patient is having splenomegaly also, because all these cells are destroyed in the spleen only. So splenomegaly will also be there, right? Coming on the lab diagnosis. Can I come on the lab diagnosis? Can I come on the lab diagnosis? In the lab diagnosis, you always have to look for the 5 things. Take out the blood of the patient and look, do the blood investigation. Take out the bone marrow, do the bone marrow aspirate and bone marrow biopsy, and you can look in the bone marrow also, right? Take out the sample, like you can take blood sample also, and do the cytogenetics, in which we will come to know the exact mutation. Cytogenetics can be come on and can be done on any cell, the blood cell or bone marrow cell. We can do special stains. The special stains are known as cytochemistry, and there are others. So in the blood we have to look for 3 things: RBC, WBC and platelet. What about the hemoglobin? RBCs, you will say ma'am, RBCs are less, platelet are less, but WBC are more. WBC are more. The WBC which are more, they are immature. The WBC. So let's make a smear. This is the smear you are getting. So you will say ma'am, what are all these cells? In the cells you can see eosinophils are there, the red granules. You can see basophils are there. You can see this is a normal neutrophil. So these are the mature form, but they are very less in number. I can get eosinophil, basophil and neutrophil, but they are less. The mature form are less. Most of the cells are immature. Most of the cells are immature. What I am getting in immaturity, I can get a blast, myeloblast, promyelocyte, myelocyte, metamyelocyte, band form. These all are immature versions. Immature versions. Same. So this is known as garden party appearance. See this diagram. What all cells you are getting? You are getting the all type of cells. You are getting promyelocyte also, metamyelocyte also, band form also, basophil, eosinophil, neutrophil, you are getting all. So multiple type of cells in the smear is known as garden party appearance. This one is known as garden party appearance because everyone is in unique dress. So this is a typical picture of CML. Now you cannot identify, you may be thinking ma'am, how to identify which is promyelocyte, metamyelocyte and band form. At your stage we are not considering you to identify. Band form is easy to identify. It's the C-shaped structure. Can you see it's a C? It's like a curve. It's like a C-shaped. It's like a C-shaped. So these are the band forms. Got it? Any confusion? These are the band forms. Everyone got it? So this is the blood picture. Now in the bone marrow, what you will get? You tell me. So first question, bone marrow cellularity. Cellularity. This is the bone marrow. This is the hematopoietic stem cell. Lymphoblast, myeloblast. You tell me cellularity is increased or decreased? In CML, the cellularity of the bone marrow, the cellularity, I am asking you, the cellularity is more or less? The cellularity is of course more, because we are getting uncontrolled mitosis of the precursors. Because of uncontrolled mitosis, you will get hypercellularity in the bone marrow. If you take the bone marrow aspirate, you will get the cells are more than normal. It's hypercellular. Which cell? Myeloid or lymphoid? You will get all the cells are myeloid. Hardly you will get any lymphoid cell, because they are replacing the lymphoid cell because of uncontrolled mitosis. So ME ratio will reverse. It is known as myeloid erythroid ratio. Most of the cells are myeloid. So ME ratio is increased. Myeloid, not reversed. ME ratio is increased. M is more, E is normal or less. So ME ratio, numerator is more, denominator is less. So the ME ratio will increase. The RBCs are less and the platelets, megakaryocytes are the precursors of the platelet. So RBC precursor and platelet precursor are less. This is the bone marrow picture. Now doing cytogenetics. In cytogenetics, you come to know the exact chromosomal abnormality. So what is the exact abnormality? It's 922 translocation, that is ABL-BCR translocation. You will get the exact chromosomal abnormality in cytogenetics. That is the test for diagnosis, the most important specific test, but it's costly. And then coming on the cytochemistry. In cytochemistry, you can use special stains. You can use special stains. There are certain special stains we can use. The most important special stain we are using here is neutrophil alkaline phosphatase. Neutrophil alkaline phosphatase, also known as leukocyte alkaline phosphatase, LAP or NAP, one and the same thing. Neutrophil alkaline phosphatase or leukocyte alkaline phosphatase. So basically when normally, this is normal and this is CML. So let me draw a neutrophil here. In the neutrophil normally, this is the multilobated nucleus of the neutrophil. So this is normal, healthy neutrophil. So in the cytoplasm, granules are present. Normally, granules are more. So NAP stain the granules. You are getting my point. So there is a granule that is stained by the NAP or LAP. But in CML, the premature forms are there. Mature neutrophil is not there. The premature forms are there. Premature forms do not have much granules. They do not have much granules as compared to mature form. They have less granules. So here if you do the NAP score is more. And here if you do the NAP score is less. So basically you have to learn. If you understood, it's good. Otherwise learn that in CML, the NAP or LAP score is less. Okay, you can see the NAP or LAP score. It's less in CML. It's less. In CML, it is reduced. The score is reduced because granules are less. Got my point? Okay, got my point. A mature form will not mature after coming in the blood cortex. After coming in the blood, the immature form will not mature. Immature will remain as immature only. Got it? And in other findings, hyperuricemia will be there. Uric acid will be more because there is abundant of WBC. No, normally WBC are 11,000, but instead of 11,000, here WBC are in lakhs. Once they are formed more, they are destroyed more. Once the cells are destroyed, it will lead to uric acid formation. So patient will be having hyperuricemia or gout. So this is others. So can you summarize the lab diagnosis? Say, ma'am, in blood picture, the hemoglobin is less, RBC is less. The platelet is less, but WBCs are more. But write on the word garden party appearance. You can learn the image. So you will get all type of cells. What type of enumerate? What type of cells you are getting? You are getting myeloblast, promyelocyte, myelocyte, metamyelocyte and band form. Garden party appearance. Coming on the bone marrow now. Bone marrow cellularity will be more. Most of the cells are myeloid, not erythroid. But erythropoiesis will be less and megakaryocytes will be less. I know. Cytogenetics, you get the exact abnormality. The most specific test among all is cytogenetics. You will get Philadelphia chromosome. In cytochemistry, then you have to calculate the NAP score, या फिर LAP score. So that is neutrophil alkaline phosphatase or leukocyte alkaline phosphatase, but these scores are less. And in others, the uric acid concentration will be more. How many of you got it? So this is the summary of the lab diagnosis on which you get the question. Now finally the treatment. How we treat the CML. So first thing, we have to manage the bone marrow failure. If the patient presents with anemia, give RBCs, RBC transfusion, blood transfusion. If the patient presents with bleeding, give platelet transfusion. Patient have less RBC, less platelet. So you can give the RBC and give the platelet. You can give the transfusion. So that we can do. But there is a specific therapy available, the targeted therapy. It is known as imatinib. The targeted therapy is imatinib. Very important question. Very important. It causes apoptosis of all the cells which contain the fusion gene, and the prognosis of CML is very good because of the imatinib. It's a oral, it's not injectable, it's a oral therapy. Daily patient has to take one tablet. It's costly, but. And finally, this bone marrow transplant is also available if the donor is there, if HLA match donor is there. Okay, got it. Anyone have any confusion? Last thing, the prognosis. What is the prognosis? There are two index. There are two index in the prognosis, Sokal index and Hasford index. These are the name of the scientist who has given these index. So there are 5 criteria here. There are 5 criteria. 4 are same. The 5th one is the different. Hana? In both of them, I guess age is there. In both of them, platelet count is there. In both of them, spleen size matters. In both of them, blast is there. Hana? I've written haphazardly, but you can see 4 are same. But the 5th criteria is different. Here cytogenetic changes are there, and here the percentage of basophil and eosinophils are there. So based on the 5 finding, we can find the patient prognosis is good or bad. The patient prognosis is good or bad. Got my point? You have to learn that. Anyone have any confusion? Let's solve some MCQs based on CML. Out of the 4 leukemias, 1 is done. I want to teach you 4 today. I'm teaching you leukemias. I'm done with CML. The first is CML only. In a comparative manner, I'm teaching you AML now. After that, we will come on ALL. And after that, finally, we will come on CLL. So today's session is all leukemias in one shot, so that you have a comparative analysis of all leukemias in one go. How many of you got it? How many of you got it? That is leukemia. That is leukemia. So we have seen the first one. Now we will revise it under all the headings. We will revise. Before that, let's solve some question. I want you to answer the question. Please answer the question. Please answer. So question is very simple. These are the questions already asked in the previous year questions in various competitive exam, Neetpg, FMG, right? First question, ABL BCR hybrid gene is present in which malignancy? I guess the question is very simple. Is it Burkitt lymphoma? Is it retinoblastoma? Is it breast carcinoma or is it CML? Can you answer it in the chat box? What is the correct answer? Thank you, Sneha. Sneha, can you answer it? Others, can you answer it? Yes, the correct answer. Obviously, it's CML. And what is this hybrid gene located? It is that chromosome is known as. The chromosome on which this hybrid gene is present, that is known as Philadelphia chromosome. Philadelphia chromosome. Philadelphia chromosome is chromosome 9 or chromosome 22? I'm asking you. Is it 9 or 22? It's 22. Because the fusion is formed on 22, not on 9. Huh? So these all are your questions. Coming on the next question is looking a little bit bigger, a clinical question. Let's take the clues. Let's take the clues one by one. So there is a 60-year-old man. See the age. Age is always a clue. Age is always a clue. So I told you CML occurs after 50 years mostly. So there is a 60-year-old man having fatigue. Fatigue indicates patient have anemia. They are not saying you directly anemia. They are giving you an indirect clue that the patient is having anemia. Patient have fatigue. Patient have weight loss. Patient have heaviness in the left hypochondrium since last 6 months. Hemoglobin is 10. See the patient is anemic. है ना? And TLC is 5 lakh. Oh my god. Normal total leukocyte count is 4,000 to 11,000. Normal range is 4,000 to 11,000. Here it's 5 lakh. 5 lakh. So obviously it's a straightforward case of leukemia. Platelet is normal. It's 4 lakh. Normal platelet is 1.5 to 5 lakh. Here it's 4 lakh. It's normal. Right. Now differential count. See, total 5 lakh may say what is the percentage. So neutrophils are there, lymphocytes are there, monocytes are there. These are the mature. Basophils are there. But the patient also have metamyelocyte, myelocyte, promyelocyte and blast in the blood. So it's a garden party appearance. So answer is, my diagnosis is CML. My diagnosis is CML. And what is the answer? What is the answer? It's 922 translocation. We know in CML the translocation is 922. That's why answer is B. So first make the diagnosis that it's a typical case of CML. You can get the 4 option in the 4 leukemia instead of this. So is it CML, AML, ALL, CLL? So answer is CML because it's a garden party appearance. Can I start the next leukemia? How many of you are with me? Do you have any doubt in CML? We are done with CML. Okay. I told you the definition of the CML. I told you the pathogenesis of CML. We have seen the clinical features. We have seen the lab diagnosis. We have seen the treatment. We have seen the prognosis. Anyone have any confusion? Huh? Anyone have, you know the pathogenesis? It's 922 translocation. That is ABL BCR translocation. Okay, clinical features I told you, due to marrow failure, patient have anemia, bleeding and high chances of infection. Okay, and patient can have lab diagnosis. We have discussed blood picture, bone marrow picture, cytogenetics. Likewise, we have completed. So let's come on the next leukemia. The next leukemia we have to cover is acute myeloid leukemia, AML. Let's come on the next leukemia. The next leukemia is AML. So CML is done. Now coming on AML. What will happen in the AML? First thing, AML occurs in middle age, 50 to 40. The peak age is 50 to 40. CML was occurring in old age, after 50s. After 50s, okay? And here it is the middle age. It's not late. It's not old age, I mean. So age is always a clue. I say it again and again. Age is always a clue. So what is the mutation here? Listen my point. Let me tell you a drastic difference, a very important difference between CML and AML. Both are myeloid, but see the difference. You yourself will realize the difference. This is the bone marrow. What is the first cell? The first cell is hematopoietic stem cell. Okay. Now it is forming the 2 precursor. Lymphoblast, I am currently not interested in that because I am teaching you myeloid leukemias. So I am interested in myeloblast. This is myeloblast. Normally myeloblast give rise to what? It give rise to promyelocyte, myelocyte, metamyelocyte, metamyelocyte, band form, neutrophil, eosinophil and basophil. It's like that. And the mature forms comes in the blood. This is the blood vessel. In the blood vessel, the mature forms are coming. Immature normally do not come. What was happening in CML? You see, ma'am, CML in all these cells, all the 5 precursor. Which are the 5 precursor? People, what are the 5 precursor? Say, ma'am, myeloblast, promyelocyte, myelocyte, metamyelocyte, band form. In all 5 precursor, 922 translocation was taking place in CML. That's why they all were doing uncontrolled mitosis. And because of the uncontrolled mitosis, they all were moving in the blood. So in the blood, I was getting 5 type of cell. Along with the mature one. Mature one are also there, but very little in amount. But I was getting myeloblast, promyelocyte, myelocyte, metamyelocyte band formed along with neutrophil, eosinophil, basophil. The garden picture appearance. This was the story of CML. In CML, this was happening. Let me come on AML now. Let me come on AML. See what is happening in the AML. In the AML, mutation take place only in myeloblast, not in others. The mutation take place only in myeloblast. There are many. You will ask, ma'am, which mutation? There are many mutation. Basically, there are many mutation. Most important you have to learn. It's 821. It's 1517. These are the various translocation. I will give you more. So these are the translocation taking place. But the point to be noted, it's only myeloblast, not other precursor. So only myeloblast will do uncontrolled mitosis, and only myeloblast will come in the blood. So in the blood you will get only one cell, that is myeloblast. You will not get promyelocyte, myelocyte, metamyelocyte band form, and hardly any mature form. Mature form are also almost absent, very little in amount. 99% cells are the myeloblast. Say yes. So this appearance is not garden party. It is known as school uniform appearance. School uniform. Everyone is in the same uniform. So only one type of cell is there, myeloblast. Say yes. You are getting it, huh? You got the difference between CML and AML. In CML, all the 5 cells are coming, including myeloblast. In AML, only myeloblast. How many of you got it? How many of you got it? Huh? So these are the translocation taking place in myeloblast. In myeloblast, it can be 821, it can be 1517, or it can be inversion 16. These are the two translocation. This one is inversion. You know the meaning of the inversion? This is chromosome number 16. Imagine this is chromosome number 16. So this is a segment of gene there. So what does this is point A, this is point B. It will come out and reverse and join again. So B was below normally, and now B will be above, A is below. This is known as inversion. It's a type of mutation. It is inversion. Yes. So mutation takes place only in myeloblast. That is the thing. Now coming on classification. Acute myeloid leukemia AML is of 8 type. 8. How many types? Say ma'am, 8. 8 type. This classification is known as FAB classification. What is the full form of FAB? French American British classification. FAB. French American British classification. So total 8 type of AML is there. M0, M1, M2, M3, M4, M5, M6, M7. Starting from M0. Total 8 are there. You have to learn this classification. You have to learn the names. AML के क्या क्या नाम है. So M0 is known as minimally differentiated AML. It's minimally differentiated. ठीक है. M1 is AML without maturation. M2 is AML with maturation. Learn these 3 names. Without maturation, with maturation, and this one is minimally differentiated. Coming on M3. Listen. It's easy. M3 is promyelocytic leukemia. This is promyelocyte. M4 is myelomonocyte. This was promyelocyte, this is myelomonocyte, and M5 is monocyte. This is promyelocytic leukemia, this is myelomonocytic leukemia, this is monocytic. Learn like that. Okay, after that erythrocytic leukemia, and after that megakaryocytic leukemia. Erythrocytic is RBC, megakaryocytic is platelet. You got it? We will try it again. Tell me the names. Say ma'am, M0, M1, M2, M3, M4, M5, M6, M7. ठीक है. So this classification is FAB classification, French American British classification. So this classification we use everywhere. ठीक है. So M0 is minimal differentiation. M1 is without maturation, and M2 is with maturation. This is based on differentiation and maturation. Learn these 3. After that, from M3 onwards, it's promyelocytic leukemia, acute promyelocytic leukemia known as APML, acute promyelocytic leukemia, then acute myelomonocytic, then acute monocytic, then acute erythrocytic, and then acute megakaryocytic. Mega. So these are the classification. First learn the names. Give me a thumbs up. How many of you got it? How many of you got it? So please learn. Okay, please learn that. Okay, so this is, now I am telling you the peculiarity of all 8 on which you get the questions. M0 is only among all of them, among all the 8, which will be MPO negative. MPO is a special strain. It will be MPO negative. M1 nothing important. Yeah, M2 mein most important translocation is 821. 821 leads to M2. 1517 leads to M3. Okay, and inversion 16 leads to M4. You have to learn these. There is 911 in M5. You have to learn. So there is no important translocation in M0 and M1. But M2 onwards you have to learn. It's 821 in M2, it's 1517 in M3, it's inversion 16 in M4 and 911 in M5. Got it? M6, M7, nothing important. M7 is the least common time. Least common among them is M7. M7 is the least common and M2 is the most common. So among all, M2 is most common, M7 is least common. But in Down syndrome, most common M7 occurs. Most common M7 occurs in Down syndrome. How many of you got it? Any confusion? So I told you M0, M1, M2, M3, M4, M5, M6, M7. First learn their names. After that I told you the peculiarity. This is most common, this is least common. Okay, you have to learn that. Okay, and you have to learn their names also. Okay, and after that coming on the clinical features. In the clinical features, the three things are common. It's anemia. The patient is having anemia because the RBCs are less. The patient is having bleeding disorders because the platelets are less. And the patient have infection. Although the WBCs are more, still the patient have infection because most of the WBC are myeloblast. They are immature. 99% of them are myeloblast. Okay, so infections are common. Although the patient have more WBC, still the infections are common. Okay, now there is a difference. There is a difference in CML and AML clinical feature. So I have to draw this diagram again. This is the blood and these are the solid organs. Okay, now the first cell here is the hematopoietic stem cell. Please understand. This is lymphoblast, myeloblast, promyelocyte, myelocyte, metamyelocyte, band form, neutrophil, eosinophil, basophil. I guess everyone knows this diagram now. What was happening in CML? All these cells was coming in the blood. After coming in the blood, they remain in the blood only, garden party appearance. They don't enter in the solid organ. So they have the picture of anemia, bleeding disorder and increased chance of infection. That were the clinical features, only three clinical features in CML. What I am saying in AML? In AML, they all are not coming in the blood. Only one is coming in the blood. Which one? Myeloblast. Only myeloblast is coming, others are not coming in the blood. Mutation takes place only in myeloblast. But after coming in the blood, it enter in the solid organs and it produced discrete masses in the solid organ. That was not happening in CML. So in AML, we have blood में anemia, thrombocytopenia and infection. That is common in the two. But these findings in which the solid organs are involved, that is present only in AML, not in CML. How many of you got it? कितनों को समझ में आया? You got my point? So my point is that in CML and in AML, what is the clinical feature? Same ma'am, bone marrow failure in both of them. Here also we have bone marrow failure and here also we have bone marrow failure. Okay, bone marrow failure means bone marrow is not synthesizing RBC. No RBC means patient have anemia in both of them. No platelet, patient have bleeding disorder in both of them. है ना? Although WBCs are more here also and here also, but they are immature. Here the WBCs which are more, they are the garden party appearance, and here the WBC which are more, it's school uniform appearance, that is myeloblast. So although the WBC is more, patient is having high chances of infection. Okay, but along with that, we have one more finding here in AML, that is organ infiltration. What it is known as organ infiltration. Here we don't have organ infiltration. So these blasts after coming in the blood, they enter in various organs. है ना? So organ infiltration. Which organ? Can you enumerate the name of the organ? It can go in the bone, producing bony pain, especially sternum, and produce sternal tenderness. I'm talking about AML. Okay, they can enter the lymph nodes and produce lymphoadenopathy. They can enter in the spleen, producing splenomegaly. They can produce in the liver, go in the liver and producing hepatomegaly. So liver can be enlarged, spleen can be enlarged, the various lymph nodes can be enlarged, the bones can have the tenderness, sternum can have the tenderness. They can enter in the kidney and destroy the kidney, causing leukemic infiltration of the kidney. They can enter in the gums. You know, over the teeth we have gums. See, gum infiltration, very peculiar finding. Gum hypertrophy, the gum infiltration, because the blasts are entering and producing the infiltration. It is seen in M4, M5. Write down M4 and M5 variants show gum hypertrophy. Only M4, M5, it's very important. It's very important. Got it? And sometimes they can enter the skin of the orbit and producing proptosis. In the orbit, it is causing proptosis. It is seen in M2, it is known as chloroma. So that is chloroma. What is chloroma? They can enter in the skin They can enter in the orbit producing proptosis. It is especially seen in M2. They can involve the brain meninges also. They can involve the brain meninges also. Got it? So organ infiltrations में these all are important. So it can be lymph node, it can be hepatomegaly, it can be splenomegaly, it can be kidney, it can be gums, it can be orbit. If it is gum, it is known as gum hypertrophy. And if it is orbit, it is known as chloroma. So gum hypertrophy is seen in M4, M5. Okay, and chloroma is seen in M2. You have to learn that. There are questions in that. Do you have any confusion? Yes, cortex, I agree that myeloblasts are also present in CML, but they don't infiltrate. In CML, there is no infiltration in the organ. In AML, there is infiltration of the organ. Does anyone have any confusion? Can we proceed? So what is the lab diagnosis? In the lab diagnosis, again, same 5 things we will do. The blood picture, the bone marrow picture, cytogenetics, cytochemistry and others. In the blood picture, you tell me the same 3 things. What happened to hemoglobin? Of course, it will fall. What happened to platelet? Of course, it will fall. What happened to WBC? Of course, they rise. But here, it's not garden party appearance. Only one WBC, that is myeloblast. So you will say, ma'am, anemia is there? Yes, RBC is less. Thrombocytopenia? Yes, it is there. But WBC are more than 1 lakh. But they all are myeloblasts. See the diagram. Now compare this with that. See the diagram. I can see only one type of cell. See this cell, see this cell, see this cell. They all are myeloblasts. See this cell. The peculiarity of the myeloblast. The peculiarity of the myeloblast is that in the cytoplasm you can get iron rod. See the cytoplasm. Can you see the iron rods in the cytoplasm? Rod like red rod like structure. These are known as iron rods. Iron rods. So a myeloblast containing iron rod is known as Fagott cell. Fagott cell. What is a Fagott cell? See ma'am, Fagott cell is a myeloblast. It's a myeloblast and it contains iron rod. It contains iron rod. It contains iron rod. Any confusion? See the diagram. See the diagram. Can you see? It's school uniform appearance. They all are same cell. Compare with that. It was garden party. This is school uniform. They all are same. Basically, they all are myeloblast. How you recognize, ma'am, these are myeloblasts, these are not lymphoblast? See the cytoplasm. First thing, cytoplasm is abundant, it's moderate, it's not scanty, number 1. And number 2, in some cells, see this cell? I can see the red rods, see this cell and see this cell. In few of them, I can see iron rod. Iron rod never present in lymphoblast, they are present in myeloblast. Now compare, I have covered 2 out of the 4. Which 2 I have covered? I have covered this one and this one. Compare the blood picture. Rest 2 we are covering. Basically, we are done with myeloid leukemias. And now I will be starting the lymphoid leukemias. How many of you are with me? Now I will be starting the lymphoid leukemias. We are done with myeloid leukemias. Any confusion anyone is having? Say people, say, respond. So in myeloid, just compare the 2. Compare, see all the cells here, see all the cells here. Say ma'am, here all the cells are same. Say school uniform appearance. And here all the cells are different. Say it's garden party appearance. So what all cells we are having here? Say only one type of cell, ma'am, myeloblast. And what all cells we have here? Say ma'am, myeloblast, promyelocyte, metamyelocyte, myelocyte, band form. These all are there. Please appreciate my efforts. You got my point. So coming on the lymphoid leukemias, before that we will solve some questions also here. This is the blood picture we are done. After that, coming on the bone marrow. Obviously here also cellularity will be more. Obviously here also most of the cells are myeloid only. RBC will be less, platelet will be less. So everything is same here. Cytogenetics, you get the exact abnormality. If it is M2, it's 821. If it is M3, it's 1517. If it is M4, it's inversion 16. So these are ultra important you have to learn. In the cytochemistry, you have to learn the 3 stains. Please, it's important. Cytochemistry, you have to learn the special stain. The 3 special stain. What are the 3 special stain? One is NSE, non-specific esterase. The second is PSA, periodic acid swap, PSA. And third is acid phosphatase. So NSE, PAS and acid phosphatase. So all these, I'm sorry. PS and acid phosphate will be negative, I'm sorry. The first 3, MPO is always positive here in all type of AML except M0. M0 chhod ke in every one of them MPO is positive. And Sudan black is always positive, NSE is always positive. These 2 are negative. PAS and acid phosphatase will be negative. So MPO, Sudan black and NSE. These 3 are always positive. But PAS and acid phosphatase will be negative. Listen. How to learn this? Listen, I am teaching you 4 leukemias. The first CML is already done. And now I am teaching you the second one, AML. After that, I will come on the third one, ALL. And in the last, I will teach you CLL. In this sequence, I am teaching you. Let me write the cytochemistry of the first three. Here I told you have to calculate NAP score. Have I taught you NAP score? Huh? So NAP score या फिर lab score. NAP या lab score. Okay? It is reduced here. Here we have to do 3 stains. What 3 stains? Now let me write the name of the 5. Listen. The first is MPO. The second is Sudan black. Third is NSE. The next is PAS. And last one is acid phosphatase. So I mean to say these 3 are positive here in AML and these 2 are negative. But reverse happen in ALL. These 3 are negative here and these 2 is positive. How many of you got it? How many of you got it? So this is the special stains in AML and ALL. These are the special stains known as cytochemistry. ठीक है? Say yes, respond. So this is the cytochemistry of the CML, AML and ALL. And finally we will come on CLL now. So this is the cytochemistry. ठीक है? Uric acid is always raised in all these leukemias. So that is the thing. Now coming on the treatment. In the treatment, the first treatment is supportive. In the supportive treatment, if the patient have the anemia, give platelet. If the patient have bleeding, if the patient have anemia, give blood transfusion. If the patient have bleeding, you have to give platelet transfusion. This is supportive treatment. Here there is no targeted therapy like CML. In CML, we have a targeted therapy. The name of the targeted therapy is imatinib. Here we don't have imatinib. Right? Here what we have is the chemotherapy. Here we have chemotherapy. So in the chemotherapy, various chemotherapy regimens are available like cytosine, arabinoside, anthracycline, 6-thioguanine. You have to learn the chemotherapy. We have to learn the chemotherapy. For M3, special treatment is available, that is tretinoic acid. And bone marrow transplant is always the option if the donor is available. So we are done. In the last, we have to see the prognosis of AML. So let's come on the prognosis of AML. Prognosis. So you have to learn. I have told you prognosis there also in CML. I told you 2 criteria. SOFAX and HASPOD. I told you 5 criteria in each of them. The 2 different type of prognostic index we use. Here prognosis is good prognostic factor and bad prognostic factor. You have to compare. If the age is less than 40, it's good. है ना? But extremes are bad. Less than 2, या तो बहुत छोटा या तो बहुत old. So either the infants or the old person, the senior citizen. Less than 2, more than 55 is bad. But middle age is good. Middle age is good. M2, M3, M4 is good. M2, M3, M4 is good. But M0, M6, M7 are bad. Please learn. What is the mutation in M2, M3, M4? I told you mutation in all 3. In M2, it's 15, 17. In M3, it's 821. I said the reverse, I'm sorry. In M2, it's 821. In M3, it's 15, 17. In M4, it's inversion 16. So all these are good. And remaining all will be bad. Remaining all will be bad. है ना? So you have to learn this. Blast with IR rod is good. But complex karyotype is bad. So you have to learn the good and bad prognostic factors here. Okay, read the question, tell me the answer. We are done with AML also. We are done with CML, we are done with AML. Now I will teach you the lymphoid leukemias. Now we will come on lymphoid leukemias after this. So first, read the question. Read the question. All of the following are poor prognostic indicators except. I am asking except. What will be the correct answer? So inversion 16 good or bad? Complex karyotype good or bad? AML M7 good or bad? And deletion 7q is good or bad? They are asking all are poor except. So tell me which one is good. So only one of them is good, that is inversion 16. I told you inversion 16 is coming in the good. Rest all are coming in the bad. Okay, so you get questions on the prognostic factors. One more question, tell me the type of the AML which show gum infiltration. Gum infiltration is peculiarly seen in M4 and M5. I told you. So M4 is there in the option, I will go with M4. Gum infiltration seen in M4. If I change the question from gum infiltration to chloroma, what is chloroma? Here the orbit is involved. Then it is seen in M2. In that case, answer will become M2. Right? Now tell me the next AML with the worst prognosis. Which is having the worst prognosis? 821 is good. Inversion 16 is good. Normal cytogenetics is good. But monosomy 7 is bad. I told you, na here. It's 7q and 5q. That is monosomy. Monosomy of 5 and 7 is bad. So you have to learn the prognostic factors. Okay. The next question. IR rods are seen in. Obviously, IR rods are seen in. Is it lymphoblast, myeloblast, erythroblast or megakaryoblast? So obviously it's myeloblast. Obviously it's myeloblast. Okay, so let's move ahead. Let's move on the next leukemia. We are done with CML. We are done with AML. Coming on the third one now, ALL. The third one is ALL. Can I start ALL? Let's start ALL. The third one is the ALL. In ALL we have two type. है ना? Now we will talk about the lymphoid side. है ना? So let me draw the bone marrow again. This is the bone marrow and this is the blood vessel. ठीक है? This is hematopoietic stem cell. This is hematopoietic stem cell. This is myeloblast. This is lymphoblast. What are the precursors here? Say it once. Promyelocyte, myelocyte, metamyelocyte, band form, and finally neutrophil, eosinophil, basophil. What are the precursors here? This side, only one precursor. Lymphoblast se banega prolymphocyte and it gives rise to lymphocyte. This is mature. This is mature. Now let me tell you what was happening in CML. In CML, in all of them, mutation was there and they were doing uncontrolled mitosis. They all were coming in the blood. So CML, it was a garden party appearance. This is CML. Now let me tell you what was happening in AML. In AML, only myeloblast was coming in the blood. Mutation were taking place in myeloblast and only myeloblasts were coming. Others were not coming. Right? That is AML. If you want to say the mutation also, you can revise that also. In CML, the mutation was only 1922 translocation. That is Philadelphia chromosome, ABL, BCR. That is taking place in all these cells. But in AML, various types of mutations are there depending on the type. If it is M2, it is 821. If it is M3, it's 1517. And if it is M4, it's inversion 16. So whatever is the mutation, ultimately it is taking place only in myeloblast. And only myeloblast come in the blood. Got my point? Now, we will come on the lymphoid side. In lymphoid side, now the mutation will take place in prolymphocyte. The mutation will take place in the lymphoblast. The mutation will take place in the lymphoblast. So only lymphoblast will come in the blood. Only lymphoblast, not all. Only one lymphoblast will come in the blood. Now there are two type of lymphoblast, pre-B, pre-T. Because lymphocytes are of two type, now B and T. So it is of two type. You got my point? You got my point? Just a second, give me a minute. I'm sorry. So pre-B cell ALL and pre-T cell ALL. These are the two types. Okay. And here the mutation, I will tell you the mutation also, don't worry. The mutation will be in the lymphoblast. Okay, only lymphoblast will come. Again, school appearance, school uniform. But this time it's not myeloblast, it's lymphoblast. It's without iron rod. And it occurs in children. It occurs in children. See, age is very peculiar, I told you. So I told you CML first. I told you it occurs more than 40 years. For 50 years of age, in old age. I told you in AML, it occurs 15 to 40. And now I am telling you ALL. It occurs in children 3 to 5 years. Or in adolescents. How many of you got it? Age is very important. It will be a clue for you. It will always be a clue for you. Got it? Any confusion? Now the pathogenesis you were asking, now the mutation, these all mutation can occur. Don't learn, have a look. There can be hyperploidy, there can be hypoploidy because of the mutation. Hyperploidy. There can be PAX5, E2A, EBF gene mutations. There can be 1221 translocation and there can be 922. Yes, 922 is common in CML and ALL. 922 can also occur here. 922 can also occur here. So what is the difference between the 922 in CML and what is the difference between 922 translocation in ALL? I am saying 922 occurs in both. So there also the fusion gene is formed, the hybrid gene ABL-BCR. Here also the fusion hybrid gene is formed. The size of that hybrid gene is different. In CML, the size of the hybrid gene is 210 kilodalton. I told you there also. But here the size is only 190 kilodalton. The size of the hybrid gene, right? These are the mutation. Have a look on them. Now, according to the FAB classification, French, American, British classification, ALL is of three type: L1, L2, and L3. Three type of ALL is there: L1, L2, L3. L1 is the commonest, having the best prognosis. L3 is the rarest, having the worst prognosis. It's the rare, having the worst prognosis. Okay, so that is ALL. So clinical feature. Again, my question is same. Will it show organ infiltration? Yes or no? This is bone marrow, this is blood, and this is organs. This is hematopoietic stem cell, this is myeloblast, this is lymphoblast. I'm comparing AML with ALL. What was happening in AML? Myeloblast was coming in the blood. This was coming in the blood. And in ALL, I'm saying lymphoblast is coming in the blood. In ALL, the lymphoblast is coming in the blood. You are getting it? Myeloblast, lymphoblast, है ना? In CML I told you everyone was coming, but here only one of them is coming. My point is that myeloblast also show infiltration, lymphoblast also show infiltration. So like myeloblast only, here lymphoblast also show multiple organ infiltration, but organ predilection will be different. Predilection will be different, but it show organ infiltration. In myeloblast, it was going in the gums, showing gum hypertrophy. It was going in the orbit. It was going in the meninges. Here, it will go in the mediastinal lymph node. It will go in the mediastinal lymph node. It will go in the testes. So organs are different, but organ infiltration will be there. So here also we have bone marrow failure. Bone marrow failure is common in all anemia, all leukemias. Patient have anemia in all leukemia. Patient have bleeding disorder in all leukemia. Patient have high susceptibility of infection in all 4 leukemia. ये तो common है. Bone marrow failure चारों leukemia में होगा, right? Here we have organ infiltration. Here we have organ infiltration. Bone marrow, bone pain can be there. Lymphadenopathy, splenomegaly, hepatomegaly can be there. But CNS involvement is more here. Testes involvement is more here. Mediastinal lymph node involvement is more here as compared to AML. How many of you got it? How many of you got it? You are getting it? Respond. Say yes, say no. You are getting the differences between different types of leukemia. Different type of leukemia. You are getting the differences, yes or no? So coming on the lab diagnosis here. In the lab diagnosis, the blood picture, bone marrow picture, cytogenetics and cytochemistry. Blood picture you already know. The RBC will be less, WBC will be less, but platelet will be less, WBC will be more. RBC less, platelet less, but WBC will be more. Which WBC? Only one type of WBC. Again a school uniform appearance, but all of them are lymphoblast. See the picture. They all are lymphoblast. School uniform appearance. They all are lymphoblast. They all are lymphoblast, not myeloblast. They all are. How to recognize they are not myeloblast? See the cytoplasm. Can you see the cytoplasm? I can't see. I can see only nucleus. Hardly any cytoplasm. Scanty and no iron rod. I was seeing iron rod there. Compare. Comparison is the best thing you can do it here. I taught you 3 till now. I taught you CML first. See, it's garden party. Everyone is there. See the cells. Everyone is there. It contains myeloblast also. Promyelocyte, myelocyte, metamyelocyte, band form, everything is there. Here we have only one cell, that is myeloblast. And here also we have only one cell, that is lymphoblast. Compare myeloblast with lymphoblast. See the cytoplasm and see the iron rod. Here you can see the iron rods. See the iron rods. See the iron rods. Here no iron rods. So this is also school uniform appearance. School uniform. This is also school uniform. All the cells are same. But here with iron rod, here without iron rod. Here with moderate cytoplasm, here with scanty cytoplasm. And here it's garden party. Here it's garden party. I hope you are getting it. I hope you are getting it. Say yes. Here no organ infiltration, only bone marrow failure. Here along with bone marrow failure in both of them, organ infiltration is also there. But the predilection for the organs is different. Got my point? I'm trying very hard to explain you. I'm trying very hard. Got it? Okay, last one is remaining. We will come on that also. Okay, so this is the blood picture. Now coming on bone marrow examination. So here also hypercellularity is there. Of course, cellularity will increase. Most of the cells you will get blast here. RBCs will be less, platelet will be less. Cytogenetics, I already told you, it can be hyperploidy, it can be hypoploidy, it can be trisomy of 4, 7, 10, 9, 12, 12, 21, 9, 22, 4, 11. Have a look so that if it is coming in MCQ option, you can identify. You can identify. Cytochemistry also, I told you the 5 stains. No? What are the 5 stains I told you? So I want to tell you the difference between AML and ALL, myeloid and lymphoid, the acute one. So I told you 5 stains. What are the 5 stains, people? I told you MPO, Sudan black, NSE, non-specific esterase, PAS and acid phosphatase. So I told you first 3 are positive here but negative here. Last 2 are negative here but positive here. So learn the special stains. So my point is that these are the 3 for AML and these are the 2 for ALL. You have to learn. This is how you can differentiate. Although you can differentiate based on this, based on the lymphoblast or myeloblast. But still if you are getting confused, ki ma'am it is lymphoblast or myeloblast, I am getting confused. You can use special stain. You can use special stain. If it is MPO, Sudan black, NSE, it is myeloblast. And if it is positive for PAS and acid phosphatase, it is lymphoblast. I hope you are getting it. This is cytochemistry. Okay. Treatment here also chemotherapy is required. Chemotherapy is required here also. Okay. Bone marrow transplant is there and chemotherapy is required here also. Okay, coming on last, prognosis of ALL. Coming on the prognosis, we have two type of prognostic factors. Good prognostic factor, bad prognostic factor. So age 2 to 10 is good. It occurs in children, never forget. But less than 2 and more than 10, the extremes are bad. The extremes are bad. If a female child is there, the prognosis is good. Male child, the prognosis is bad. In whites, it's good. In black, it's bad. CNS involvement, testes involvement is bad. I mean, if it is they are not involved, the prognosis is good, and if they are involved, the prognosis is bad. See the cytogenetics. Hyperploidy is good. Hypoploidy is bad. Learn generalized, है ना? So you get questions on the prognosis also. Okay. So I'm skipping the question. You can do it by yourself. Coming on the last leukemia. Can I start the last leukemia? So coming on the last leukemia. Okay. The last leukemia here we are seeing is CLL. Okay, the last one, the fourth one. Then we will do a comparative analysis between all four. So the last one is CLL. CLL also known as SLL. The CLL also known as small lymphocytic leukemia, chronic lymphocytic leukemia, also known as small lymphocytic leukemia. CLL also known as SLL. Right. So here again it occurs in old age. It occurs in old age like CML only. The pathogenesis you have to learn. It can be deletion of 13, 11 and 17. 11, 13, 17, deletion. So it is monosomy. One gene is deleted. So monosomy of 11, 13 and 17. And it is trisomy of 12. है ना? So monosomy of 11, 13 and 17. है ना? And trisomy, one gene extra, one chromosome extra, it's 12. Monosomy of these three and trisomy of this. So learn the four numbers. This is the most common is deletion of 13. That is the most common. This is the pathogenesis. Clinical feature again. Here bone marrow failure is there. Bone marrow failure is there here also. But here there is no organ infiltration. Listen my words. Listen. So I am summarizing all four leukemias in front of you. If you are getting it. This is the gist I am telling you. This is the summary I am telling you of all four leukemias in this master diagram. Everyone on the screen. Listen. This is the hematopoietic stem cell. ठीक है? From which two blasts are formed. ठीक है? Myeloblast and lymphoblast. Okay. I want to see what is coming in the blood. And what is infiltrating in the organs further. ठीक है? The four type of leukemia I will summarize. है ना? Now tell me the precursors here. What are the precursors here? Myeloblast give rise to promyelocyte, myelocyte, metamyelocyte, band form, neutrophil, eosinophil, basophil. Everyone knows this till now. And here we have promyelocyte, prolymphocyte followed by lymphocyte. ठीक है? Now one by one. First I taught you the CML. I taught you in CML everyone is coming in the blood. They all are coming in the blood, but they are not infiltrating in the organ. Okay, this is CML I told you. Garden party appearance. In AML, I taught you only myeloblast is coming in the blood. Only myeloblast. CML में all are coming. है ना? AML में only myeloblast is coming. School uniform appearance. Myeloblast have the iron rod in them. Right? And they are doing organ infiltration also. In AML, organ infiltration is present. The third I taught you is ALL. I taught you in ALL, lymphoblasts are coming. है ना? The lymphoblasts are coming in the blood, and after coming in the blood, they are also infiltrating, but organ predilection is different. Again, a school uniform appearance. Now, last I am teaching you CML. You must ask me, ma'am, CML में what is coming in the blood? CML में none of the blast. Neither myeloblast is coming nor lymphoblast. CML में mature lymphocyte is coming in the blood. You may be thinking, ma'am, mature lymphocyte to already come in the blood. We all have mature lymphocyte, but these are mature lymphocyte, but these are abnormal. These are mutated, and normal count of lymphocyte in our blood is 20 to 40%. But here it is 99%. 99% of the cells will be only lymphocyte. These persons don't have neutrophil, eosinophil, basophil. They have only mature lymphocyte in their blood. That is mutated. You will say, ma'am, what is the abnormality in them due to mutation? I told you mutation. Now, either deletion, monosomy of 11, 13 or 17 or trisomy of 12. That happens in lymphocyte here. Because of which they are extra fragile. They are very fragile. They are very fragile. These are the mature lymphocyte. So here you are getting lymph nodes enlargement, hepatomegaly, splenomegaly, and see the blood picture. This is the blood picture. Can you see the blood picture? These are not blasts. What cells are these? You will say, ma'am, what are these cells? Is it myeloblast or lymphoblast? I will say neither myeloblast nor lymphoblast. No, these are mature lymphocyte. These all are small lymphocyte, mature lymphocyte. Now imagine, please understand, I'm having a patient. This is a patient. I'm having a patient. Okay, it is an old patient having splenomegaly, hepatomegaly, lymphoadenopathy, and the counts are raised, I'm suspecting the patient is having CLL. What should I do? Take the blood sample. Now here I have taken the blood sample in a test tube. Okay, just suppose my diagnosis is right and this patient has CLL. Okay, my suspicion is right. So what does the blood contain? You will see my blood contain abundant 99% of the blood cells are mature lymphocyte. These all are mature lymphocyte. Now what should I do next? You say, ma'am, make a slide, make a smear. Take a slide and just spread it, make a smear. So when I take one drop of my specimen on a slide, you know how to spread it with a spreader. At 45 degree we spread it. So once we spread it now, so these lymphocytes are very fragile. I told you, because of mutation they are super fragile. So most of them, they get fragmented while spreading. They get fragmented, and the fragmented small lymphocytes, fragmented mature lymphocytes, these are known as smudge cell. These are known as smudge cell, or also known as basket cell. Smudge or basket cell. So my point is that it's a artifact. It's an artifact while we are making smudge cell or basket cell. We don't get it in patient's body. Smudge cells are absent in patient body. We don't get it in test tube. These are present only in slide. And a smudge or basket. So in the smear you get two things. What two things? Number one, the lymphocyte, abnormal lymphocyte, and the smudge cell. Appreciate now. Appreciate now. Everyone give me a thumbs up. Appreciate. Where is the smudge cell? You all can see this is the ruptured cell. This is the ruptured cell. So these ruptured cells are smudge cell or basket cell. You got my point? So see the two findings. See the two findings. You get two things. Number one, you get mature lymphocytes. These all are mature lymphocytes. These all are mature lymphocytes. And number two, you get the ruptured. You get the ruptured cell. Smudge cell or basket cell. Ruptured cell. Say yes, people. Say yes. Summary. Summary. You want the summary? See the four smears. You get many image-based question, whatever exam you are targeting. Appreciate my efforts. Summary. The four type of leukemia in front of you. The blood picture. You tell me what you will get. You tell me. Say, ma'am, in CML we get all type of cell. We get myeloblast, promyelocyte, myelocyte, metamyelocyte, band form, neutrophil, eosinophil, basophil. Everything you can see in the blood. It's garden party appearance. Okay, in AML we get only one cell, myeloblast. See, they all are myeloblast. School uniform. They have iron rod. Don't miss the word iron rod. Whenever the word myeloblast come, write down in the bracket iron rod. They have iron rod in them, because of which we can identify them. Say yes. School uniform appearance. In ALL, again we get only one cell, but this is lymphoblast. This is not myeloblast. This is lymphoblast. It's lymphoblast. Now compare myeloblast with lymphoblast. There are no iron rod. And cytoplasm is absent here. Again, here school uniform appearance. But in CLL, we get two things. Number one, the mature lymphocytes. And number two, artifact. The ruptured mature lymphocyte because of the artifact. Because they are very fragile. So we get smudge cell also. So we are getting two things. No blast. We are getting lymphocytes. The mature small lymphocytes with the smudge cell. Smudge. See the labeling. I want you to appreciate the labeling of all four. See, in CML we are getting all cells. In AML, only myeloblast with iron rod. In ALL, it's lymphoblast. And in CLL, we are getting two cells. Lymphocyte, not lymphoblast. Lymphocyte and the smudge cells. How many of you get it? Iron rods are not seen in CML. Iron rods are typically seen only in AML. Iron rods are not seen in CML. Arun, got it? So this is the blood picture. You get many questions on that. And I hope you got the pathogenesis also. You got the mutations. Which mutation? I will tell you the mutation in different diagram. Let me finish it. Okay. So smudge cells and basket cells are seen in CLL. So basically I told you this is a mature lymphocyte. In the mature lymphocyte, actually due to the mutation, I told you the mutation hypoploidy, many mutations. Because of which the vimentin skeletal protein is deficient. Because it is deficient, it's very fragile. Because of deficiency of vimentin, it gets ruptured and it converted into smudge cell. So it is the vimentin. It is the vimentin, right? So that's it. Treatment is palliative. There is no treatment available for CLL. There is no treatment available for CLL. Finally, prognosis. Poor prognostic factors are 11 monosomy, 17 monosomy, and trisomy of 12. These are poor. ZEP17 protein is poor and Notch1 mutation is poor. You have to learn a little bit. These are the mutation which is having poor prognosis. So we are done. We are done. We will solve some question and I will summarize the 4 types of leukemia in front of you. We are done. Okay. Read the question. There is a 80-year-old male. See the age. Age is always a clue. Having painless lymphoadenopathy, painless cervical lymphoadenopathy, and peripheral smear is given to you. The peripheral smear. See the peripheral smear, I can see 2 findings. I can see the lymphocytes and I can see the ruptured cells, the ruptured lymphocyte, the smudge cells. So these 2 findings along with the age, lymphocyte and smudge cell. That finding is very typical, it's CLL. I hope you are getting it. Yes, the finding is typical. Okay, how many of you got it? Any confusion? Anyone having any confusion? Say something. So let me summarize the 4 types of leukemia. We are done with 4 types of leukemia. So in the bone marrow, the first cell is always hematopoietic stem cell. I guess everyone knows it till now. Okay, let me draw it in the center. 2 leukemias this side, 2 this side. This side I will summarize and pack. Okay, so this is bone marrow. The first cell is always hematopoietic stem cell. It gives rise to 2 blasts, 2 precursors. Myeloblast for myeloid series and lymphoblast for lymphoid series. What are the precursors this way? I guess everyone learned till now. Promyelocyte, myelocyte, metamyelocyte, band form, neutrophil in the same way eosinophil and basophil. And here we have only one, prolymphocyte, lymphocyte. Okay, now what is coming in the blood? That matters. Normally in the blood, the mature form comes. From here this and from here this. The mature form comes in the blood. Immaturities never come in the blood. But if immaturities are coming in the blood, that is known as leukemia. That is known as leukemia. So one by one we will see in which leukemia, the 4 type of leukemia, which immature versions are coming. So in CML, I told you in all the precursors, mutation take place is 922. That is Philadelphia, ABL, BCR in CML. They all will come in the blood because of the 922 mutation. Right, this is first one. Second, AML, I told you mutation takes place only in myeloblast, not in all, only in myeloblast. The name of the mutation, it's 821 in M2, 1517 in M3 and inversion 16 in M4. These are the 3 important you have to learn. Okay, and here these are the mutation that leads to AML. So in AML only myeloblast will come in the blood, not all, only myeloblast. See the mutation and see what is coming. Okay, coming on the third one, CLL, ALL. In ALL only lymphoblast will come. The name of the mutation is hyperploidy, hypoploidy. There are many, and here also we have 922. But here 922, the fusion gene is 210 kilodalton, and here 922, the fusion gene is 170 kilodalton. Okay? And finally, the last one I taught you is CLL, in which lymphocytes are coming. The mature lymphocytes having mutation in them. What is the mutation? Say either it is monosomy of 11, 13 and 17 or trisomy of 12. Most common monosomy of 13. So this is the mutation and these are coming, the vimentin is deficient, they get ruptured and they convert into smudge cells. How many of you get it? Any confusion? Anyone having any confusion? So this is the 4 type of pathogenesis, mutation, we are done. So I want you to fill this table. Just a second, let me share it. At the beginning of the lecture, I have shared a table with you. I asked you to fill this table along with me. I guess everyone can fill it now. Can you see the screen now? I guess everyone can fill this table now. CML, AML, ALL and CLL. I want you to write down, just a second. Okay. I want you to write down the definition of each of them. So exactly what thing is coming in the blood. You have to write down the definition. Age I told you. In CML I told you it's always above 50. Here I told you 15 to 40. Here I told you young age, 3 to 5 years preferably. And here again more than 60. So age is always a clue. Pathogenesis I already told you. Here it's 922, the Philadelphia. Here it's 821 in M2. For M2 it's 821. For M3 it's 1517. And for M4 it's inversion 16. Okay. Here hyperploidy or hypoploidy you have to learn. And you have to learn 922 here also, but the size is different. And here I told you monosomy of 11, 13, 17 and trisomy of 12. This is how you have to learn the pathogenesis of all 4. Okay? Say yes. Classification you have to learn. Classification, we don't have classification here and here. but here and here we have FAP classification, here also, in AML and ALL. Here we divide in 8, here we divide in 3. Here it's M0 to M8, M7, I'm sorry, and here L1, L2, L3. Hai So I have told you the peculiarities of that also. So classification is also done. Hai In the clinical features, let's come on the clinical features. In the clinical features, I told you here bone marrow failure. By bone marrow failure, I mean anemia because RBCs are less. I mean thrombocytopenia because platelets are less. And I mean WBCs are more still chances of infection. So bone marrow failure, anemia, thrombocytopenia and high susceptibility of infection. So bone marrow failure here also, here also, here also, here also. Bone marrow failure is a common finding. But here we get organ infiltration also, and here we get organ infiltration also. Organ prediction is different, I told you. So that is the summary of the clinical feature. Say yes. Lab diagnosis, I have shown you the images of all 4. I want you to learn the images. What you are getting in the blood. Imagine I have shown you the images. Here you are getting all cells. Here you are getting only myeloblast with iron rod. Here you are getting only lymphoblast without iron rod. And here you are getting mature lymphocytes plus smudge cell. If you know this, no question is going to be wrong. Treatment, I already told you. Here you have drug of choice. The drug of choice is imatinib. I mean targeted therapy. We have only here targeted therapy, no elsewhere. Here learn the chemo combination. Here learn the chemo combination. Here no treatment available, palliative. Prognostic factors you have to learn for each of them. Good, bad, good, bad, good, bad, likewise. So we are done. I hope you all got it. If you have any doubt, you are open to ask. Please ask. So in this session, we have completed the leukemias. For lymphomas, I will arrange a separate session. So currently, if you have any doubt, please ask it. You can later on write your doubt in the chat box also. So if you have any doubt, write down in the chat box. And we are going to arrange a separate session of the lymphomas. All the lymphomas at one shot. Hodgkin's also, non-Hodgkin's also. So that will be a separate session and soon we are going to plan it. I hope you enjoyed the session, you learned a lot. Don't forget to like the session. Don't forget to subscribe the YouTube channel and write your feedback in the comment box. Thank you so much for your patience and watching. And let us know what other topics you want in pathology on this YouTube channel. Let us know. We can arrange sessions for that. Thank you so much. Bye-bye. Have a nice day.